Hi, everyone. I'm Palaxini Combs, Program and Management Analyst for the DoD Medical Ethics Center. Welcome to the first of 3 panel discussions. I will be your moderator. Our panel today consists of Mr. Joseph Procaccino, Legal Advisor for the DMEC, as well as Assistant Professor at the Uniformed Services University of the Health Sciences. We also have Professor James Giordano, Bioethicist for DMEC, and Professor at Georgetown University Medical Center. We also have Dr. Megan Applewhite, who is a bioethicist at the DMEC, as well as Director of the Alden March Bioethics Institute at Albany Medical College, as well as she is an Associate Professor at Albany Medical College. Today we'll be discussing and addressing questions that were submitted by our viewing audience. So let's begin. Our first question will be addressed by Dr. Applewhite. So Dr. Applewhite, what is the best structure for a medical ethics committee? We actually have an ethics function, which is staffed mostly by personnel that rotate every 2 to 4 years. And I'm not sure that this format best serves our population, but I do not know how to structure it. So Dr. Applewhite, can you give some advice to this for this answer?
Sure. Yeah, one of the most challenging things about giving sort of blanket advice for how to structure an ethics committee is that every institution and every working center has varied access to resources and to personnel. And adding into that a high turnover makes it additionally challenging, it sounds like, for your group. So one of the most important parts about structuring an ethics committee is ensuring that you have a multidisciplinary representation. Strictly having representation from physician or from providers is not going to be adequate to assess every aspect of care that will help to answer these difficult questions that come before us. So one of the best things that we can do for the patients that we take care of who've got challenging ethical issues is to staff our ethics committee with as varied a group of people as we can, to include physicians, nurses, case management social workers, chaplains, if you can. Attorneys are a part of many bioethics committees. Community members are a really important member of ethics committees if you can get them. And there are a lot of reasons to have different perspectives to weigh in, as you can imagine, with complicated problems. We also have risk management as part of our team. We have other people from leadership, as well as floor nurses and things like that, which makes it really helpful. So with regard to the turnover, it's something that's hard to combat in a sense. So that's one of the main reasons, frankly, that we're making this training course, is so that for the centers that do have a reasonable amount of turnover, for those who have their ethics committees, who don't have a background in bioethics and who just wish to sort of have a basic understanding, it's why we're making this training course. And so hopefully this will help to mitigate any sort of loss of brain power when there's turnover, and sort of bridge the gap in a sense, or at least accelerate the education for those people who are joining and taking over after someone is left in a short term.
Great. Mr. Procaccino, do you think there should be some legal advisement on this medical ethics committee?
Well, obviously, as an attorney, I'm sort of biased in this regard, but yes, I do think the addition of having an attorney to consult with is very, very important. I second everything that Megan just said, and very, very wisely she points out that the diversity of the medical facilities. And within DoD, I think all of us realize that we are probably the most diverse and disparate as far as size and staffing of any kind of healthcare program in the world. And because of that, we have major medical centers where you have a veritable plethora of providers and staff and people on the installation that can assist. And then you also have tiny clinics where you have a paucity of those kinds of providers. And as was asked in the question, how do we accommodate a situation where you have a turnover every 2 or 3 years, just when someone feels comfortable being trained up to be able to participate, they end up PCSing or be on TDY, or you've got a situation where their workload is so heavy that this is an extra burden for them, and you find quite often that they're not able to get to meetings, and it dilutes the potency, really, and importance of the ethics committee. So when you have a large facility, what you do want to do is try to get a sense of permanency to the best of your ability, whether you use GS personnel or other folks that do have training and background. That's one of the reasons why we're offering this educational program. For those that are smaller, obviously, you do want to get providers that have some experience. And of course, it's going to depend on the specific case that's being discussed as to what kind of specialties that you want. Obviously, in addition to clinical specialties, which would include social work, which would include, as Megan said, the chaplaincy, bringing in attorneys, because the attorney will also be able to advise as far as limits sometimes of what can and can't be done in an ethical discussion. I say that because you want to be careful not to have the attorney set too many parameters that then stifles ethical discussion. The attorney should be there as an ancillary to point out issues that should be included in the ethical discussion. So when conclusory advice is being given, that all of that is taken in the mix. I would also just offer that if you do have a very small facility with turnover, there's nothing really wrong with looking at facilities that are nearby that may be larger. Since we're in a world of technology right now, we find that there is value quite often in seeking assistance on ethical questions, say from providers that are at a larger medical center that may have experience with this, that you could tap into to be able to use and include in discussion with your committees, as small as they may be. My final comment is Megan very correctly brought up that many civilian communities use civilians from the outside to sit in, community representatives. Within the government, we do have some limitations with that, and we have to be careful of that, not only because of HIPAA issues that may be discussed, but there are also some federal laws and regulations that may prohibit people that are not federal employees from participating in certain panels or discussions. So we generally don't, at least in the DoD environment, have that kind of civilian outside participation. But as far as having the medical specialties, as far as having attorney advice, perhaps a non-voting attorney, but someone there to advise, and then specialists from areas that are pertinent to the issue being discussed, I think that we can probably accomplish that if we take advantage of the technology that's available and, if necessary, tap into our sisters and brothers at other facilities. Thanks.
Great. Thank you very much. It's very informative. Okay, we'll move on to the next question. Regarding marginalized, vulnerable populations, we get a lot of cases here regarding surgeries, mostly reproductive and sterilization, on Downs and similar patients with intellectual disabilities. It would be helpful to have that issue explicitly covered, and specifically, these tend to be adult dependents of retirees. So I think, Dr. Applewhite, could you address this question?
Sure, absolutely. First and foremost, the most important thing to do off the bat is to determine whether or not the patient has capacity to make their own decisions. And I think implied with this question is that the individual does not have capacity to make those decisions, but certainly if they do have capacity for reproductive decision making, for consent to marriage, the ability to raise a child, should go without saying that involuntary sterilization is not the right thing to do for this group. However, in the absence of capacity, involuntary sterilization should really be limited to individuals who are unable to have less invasive forms of contraception. So throughout the decision-making process, it's important to consider if there are less extreme alternatives. For example, if an IUD can be placed, or if someone can utilize condoms, or if there's another way to do something that's less invasive in a patient who can't consent to a more invasive procedure that has potentially untoward outcomes and complications. Another component of this is that it's really important throughout the process to make sure that there are procedural safeguards in place that are implemented to make sure that there's a fair and consistent decision-making process. So, thinking about, as the question was asked, is that these tend to be adult dependents of retirees. It shouldn't come into play who the retiree is, right? Because if you think about rank and you think about trying to please one specific person and sort of do what they ask for you to do, and then be inconsistent when the next person approaches you who may not have been of as high a rank or who may not be as well known to you. That's inconsistent and it's unjust. And so I guess my best recommendation would be, in this really difficult scenario, first, make sure that the patient does not have capacity to make this specific decision. Second of all, if they don't have capacity, try to figure out if there's a less invasive way to solve the problem, whether it be involuntary sterilization or any other type of surgical or invasive procedure. And then thirdly, if you do determine that it is the right thing to do for this patient, make sure that there's consistency across the board with how you apply these measures and when you apply them. So in a way, protocolizing it if and when you can, just knowing that there's a lot of variability and that's really hard to do. But just sort of following those steps every time will probably make for the most fair treatment and the most beneficent treatment of those patients.
Great, thank you very much. The next question: what are we doing to protect the conscience rights of the providers that find that a specific treatment that the patient wants would not be in the best interest of the patient and would cause significant harm, or that they think would be ethically inconsistent with their own professional or moral values? This, I think, would be best answered by Dr. Applewhite and Mr. Procaccino. So go ahead. Yeah.
I'll go ahead and weigh in first over here. There are, I could say, fortunately, if you want to use that term, provisions and regulations in place within DoD and DHA regarding the ability of providers to exercise conscience clauses. The idea of a conscience clause goes back almost immediately after the decision in 1973 of Roe versus Wade and the companion case of Doe versus Bolton, which ended up leading to a system where if a provider believes that the performance in that situation, say of abortion, is something that is religiously, morally, philosophically anathema to them, that they would have a right not to have to participate in that and would not be penalized for doing so. And that passed on and is implemented within DoD to this day. That has been extended as we see more technology to apply to issues involving other reproductive matters such as sterilization and contraception. So in the area of reproduction, generally, if a method, whether it's surgical or whether it's medicinal, may be something that is in opposition to someone's religious or moral beliefs, and this would be in the way of abortion, would be in the way of certain contraceptives, such as RU486, and there are certain people, including pharmacists, that would believe that even issuing the Plan B or morning after pill would be tantamount to a pharmacological abortion, whether or not that is prescribed within the federal system, which it is not. They still have their own individual right to say no. This has also been extended in DoD language with the transgender issues and dysphoria issues that came up in the past 4 or 5 years. And we've seen kind of an oscilloscope within DoD as to whether or not we're going to treat or not treat. But now that we're in a situation where this treatment is going to be something that is real inside our facilities, the question becomes, must a provider who is opposed to surgical intervention, say, participate in that type of surgery? Again, DoD provides a conscience clause exception for those individuals to back away. When I say this, it's important to remember, however, for consistency and for the overall quality of healthcare for our population, if we are aware of those individuals that choose to express that conscience clause, we should do our best to make sure that alternatives are in place. And even those people that are refusing because of conscience clauses, that the ability for a referral to someone else who can accommodate a legal procedure can be made so those individuals can receive something that is allowable to receive within the DoD system. But again, in summary, the idea of someone being allowed to express their conscience on the issues of reproductive issues or transgender issues is there inside DoD regulation. Thank you.
And to sort of dovetail off of that great answer by Mr. Procaccino, the first part of the question, as posed to address the conscience to protect the conscious rights of a provider who doesn't wish to provide a service that they believe would be of significant harm to the patient, subtly different. So if I think that I'm going to be hurting someone by doing a specific operation on them and that those risks outweigh the benefits, according to the literature and according to best practices, I'm under no obligation to perform that operation. Non-maleficence, beneficence would, in that case, trump autonomy in a sense if you're using your best judgment, your best clinical judgment, the standards of care, and your wish not to harm a patient. Now, a question that comes in of whether or not you in that case need to refer them to someone who may perform this operation or sort of impose this intervention is another question, because it sort of depends on whether or not what they're asking someone to do is morally acceptable, and who determines that. If it's not clinically indicated, if it's not, if there's no pathology, either physical or emotional, if it's not about quality of life, and say someone just says, I'd feel a lot better without my right hand, will you take it off? And I say no, do I have to refer them to someone who will then say yes, if I feel like maybe they need another type of evaluation before someone operates on them? So it becomes a lot more weedy in that case. But I think if you think that you would cause a patient significant harm, you have to evaluate whether or not it's within the standard of care to provide that specific intervention. And if it is not, you are under no obligation to perform it.
Great. Thank you very much. We'll move into a few questions regarding research. So I think Professor Giordano can address these. The first one is, how do I know when I'm doing human subjects research? Is any planned interaction with a person where I try to learn something potentially HSR, human subject research? Professor Giordano, can you answer?
Thanks very much, Ms. Combs. Well, at first glance, the question seems to be rather simple, but perhaps it isn't. I mean, one might think that axiomatically, any type of intervention that involves humans would constitute human subject research. But the key point, the key word, is research. What constitutes research? Realistically, there are three domains and dimensions one must be aware of. Number one is there some control group to which we're taking our subjects or our patients and relegating them or assigning them by means of some form of randomization. And given that group, are we then examining differences between standards of care and some experimental or tentative procedure method intervention, and as such seeking to actually resolve equipoise, a relative capability to take two possibilities and view them as relatively equivalent so as to then examine potential outcomes so as to decide what should be done based upon what can be done. So the idea of pure equipoise and resolving equipoise in those situations in which a control group and or some form of randomization determines how the patient will be treated is an important consideration. The other is the experimental nature of the work itself, which, again, tends to build intrinsically the first principle. Are we doing this in some way that involves experimentation and something new or novel? Now, this gets a little literally gray zoned or fuzzy around its edges, because very often we may use procedures off-label, or we may use procedures in other ways, and they were intended, quote, out of the proverbial box. And in so doing, we have to then examine the third domain. What will we do with the outcomes and the results? In other words, is this for the patient's best interest and benefit, or does it then represent a larger initiative in dissemination of the information then serves a public good? So given satisfaction of those three queries, very often the rule of thumb is, when in doubt, send it out. If the individual who is the treating provider is concerned as to whether or not the interventions they're going to offer constitute experimental and or research interventions, it's always best to contact the institutional review board, or at very, very least, the chair of the review board, and have them give that work or that proposal a quick eyeball and let them determine In this way, you have the cooperation of the IRB, and at very, very least, their foresight, insight to what it is you intend to do and how it's going to be done.
Thank you. Great. This next question will be for you as well, Professor Giordano. Some health interventions are not standard or might be considered experimental, but they're provided with the intent of benefiting my patient. Do I need IRB or some other kind of approval before doing this? More generally, when does innovation become research?
I think it builds nicely upon the first question with regard to the three pillars of defining what constitutes research. Again, we'll go back to the earlier maxim. When in doubt, send it out. There are different forms of research. There's investigative research, there are formal trials, and those trials that have to be registered trials. But very often the clinician is trying to be innovative in their practice and may utilize a whole host of methods or substances or devices and interventions off-label. Let's say the actual intervention was intended for alpha, and we're using this now for Bravo or Charlie or Delta. And as a consequence, the onus of responsibility falls upon the provision of the information to that patient by the clinician. Well, this gets into the whole idea of consent to treat, but where consent to treat may involve a larger agenda. What is the issue? Is it the primacy of that patient's best interest in the clinical encounter, or is it the dissemination of information that results from an encounter more broadly to serve a public good of biomedicine, in this case, as viable research? These boundaries, as Aslan has referred to, fuzzy or gray boundaries, and very often the clinician and the myriad duties that he or she must perform somewhat confused. We'll go back to the earlier mantra. When in doubt, send it out. Informing the institutional review board and or the human subjects about the intended proposal of research and its execution provides, I think, a good stabilization, a fail-safe, if you will, to allow institutional and organization awareness, as well as insight, foresight, and approval of those things that will require formal organizational institutional review board review.
Thank you. Another question along the same lines would be, when, if ever, is it ethical to recruit coworkers, subordinates, supervisors, or family and friends to participate in a research study that I'm involved with? This may also apply for Mr. Procaccino for legal as well.
Certainly does. And I agree with you, Ms. Combs. I mean, I think there's an ethical legal boundary that exists here. And some of those legal boundaries and parameters are important to consider. You know, we'd like to think that good ethics make for good laws, but the truth of the issue is that laws govern as well as provide the capability for not only guidance, but also some form of retribution. So what we use ethics for is right and good action within the scope and content of the tenor of the law. Backing that up, to examine the ethical probity of what's involved, realistically, what we understand is we try to avoid those situations where there may be some vulnerability of the research subject. This then refers back to the National Institutes of Standards for vulnerable research subjects, and more largely, the Office of Institutional Research and Office of Institutional Care and Probity, which then defines vulnerable subjects across a array of categories. Clearly, those categories very often involve the asymmetries of the power dynamics of the relationship, dependent relationships, those relationships, for example, where individuals may not be capable or in a position to understand the scope, tenor, and implications of the research being conducted, all provide some level of vulnerability. Student colleagues, particularly those colleagues who are involved in fiduciary relationships or relationships that involve asymmetries of verticalization of rank, position, and power, all represent real tenuous areas of who can be recruited into studies and who cannot. Here, I think, once again, the mantra of when in doubt, send it out applies, but here sending it out is twofold. Certainly sending it to the Institutional Review Board for their approval of recruitment is paramount. And that recruitment may also involve review of the necessary forms and procedures for informed consent of any and all subjects who are involved. But over and above that, I think it's good to note that the Institutional Review Board, if not mandatorily, at very, very least by strong suggestion, should include legal representation and counsel, and not as a voting member, at least as a consulting member, because there are ethical issues in gauge those legal parameters that are important to dictate the ethical as well as legal probity of how we treat vulnerable subjects given the asymmetries of capability power in these relationships. To explore that further, I'd like to hand this question on over to my colleague, Mr. Joe Procaccino. Mr. Procaccino, over to you, sir.
Thanks, Dr. Giordano. When listening to you, I'm reminded of watching some of those old movies late at night about the doctors who invented the vaccines back in the 18th and 19th centuries. And because there was such skepticism, you see in some cases, and I'm sure most of the listeners can at least remember that they would end up using their children essentially as the subjects and inject into the child. And one of the reasons doing so is essentially, if I'm willing to do this to my own flesh and blood, then I'm not sure that this is an efficacious type of vaccine. Now, we've evolved a lot since then, and the points that Jim brings up are extremely valid, not only from an ethical standpoint, as he notes, but also from a legal one. The fiduciary problems that are created, the objectivity problems that are created, the perception of a power over someone, that you could end up skewing the result because of a reaction, say, from a family member or someone in a rank system that is afraid to express that there are problems, I say, with the experimentation. It ends up really quashing the value quite often of the result. And that is why both ethically and legally, those kinds of things are extremely frowned upon. Thanks.
Great, thank you. So we'll move on to our last question for today. And this is, why is it important to publish results of research and share data collected in the course research? Professor Giordano, do you want to take the lead on this one?
Absolutely. And I think, once again, it's best to approach it from a three-pronged orientation. First is, if it's not published, it wasn't done. The dissemination of that information validates it by virtue of the process of peer review. Research, science, if you will, is one of the few fields, if not the only domain, in which one is judged, quote, guilty until proven innocent. And that guilt is the looming 800-pound gorilla of the null hypothesis. In other words, these that I'm observing aren't really due to cause and effect, rather are simply due to chance. So the idea that methods, protocols, results, and conclusions must be overseen and, in fact, undergirded by the process of peer review is important with regard to the professionalism that exists within biomedical research and its advancement into the clinic. If what we're looking to do is to go from bench, proverbially, to bedside, in other words, from the experimental laboratory to clinical medicine, or going from bedside to bedside, where those things that I'm doing as a clinician become viable and therefore valid and valuable for others, they must pass the scrutiny of peer review. Even those simple things such as case reports or case series reports must be peer reviewed, at least in part, for them to gain that gravitas to then be ranked accordingly with regard to the nature of evidence-based medicine. That said, it also becomes important to understand that biomedicine and its research arm are not only an individual good, whereby patients and subjects are rendered the benefit of care, but also research and biomedical research particularly serves a larger public good. In other words, its results are not confined to the ivory tower or the confined clinic, but rather must be disseminated in the public domain to be able to uphold and support that good as being genuine in its claims, authentic in its capabilities, non-wasteful in its resources, and therefore both valid in those results, verifiable in its methods and oversight, and of value to those who are going to be sharing stakeholders. So going back to the first principle, if it's not published, it's not done. To the last principle, if it needs to be published, it's there for the public and those professions to then put into their use, becomes critical as the maxim that steers maintains the keel, as well as the point and the sail of that vessel that is biomedical research, from bench to bedside, from bedside to bedside, and as part of the biomedical triune of research, education, and practice.
And I'll add in one more thing to that excellent answer, and that is that even research that has a negative outcome, that is that you've proven the null hypothesis, right? That you hypothesized that something would be dramatically different if you intervened in some way and it wasn't. That's important to publish, because then the world will know that there is no difference. You know, trying to do an experiment a few years ago, or a clinical study, I was rolling out my protocol and I was talking to a colleague across the country about it. And he said, oh yeah, we tried to do that a couple of years ago and we didn't find a difference. And so, you know, it's not worth it. And I said, it is worth it, because I'm wasting all my time now. If you would have published that when I did the literature review to see if anybody had looked at this before, it would have come to my attention that, oh, this is something that's been looked at and done. But I think there's so much of an emphasis on being successful in proving your hypothesis, and learning something new and different, and that's better, is stressed, that people are hesitant to publish negative findings effectively, or that there was no difference, or that their hypothesis was incorrect. And similarly, I think there's sort of less bang for the journal to accept it, you know, if it's not a dramatic change to the current practice. But if some research that's being done can reinforce that what we're doing is better than another alternative, I think that's a value to put into the literature too.
And allow me to just bookend that in one way that then would also, I think, segue the question over to our legal colleague, Mr. Procaccino. You know, realistically, what we're looking to do here is to create valid results, and that validity can indeed that we did everything we're supposed to do and do it rightly, but there's no, quote, social good that can be offered by doing these procedures. And the absence of that viable good is equally important to communicate. Without opening a proverbial Pandora's box, this is what got Big Pharma and Big Tech into some hot water a number of years ago. Failure to be able to disseminate negative findings, not only to avoid the wastefulness of realistically empty replication, but also to be able to determine what works and what doesn't. And perhaps from that point to then ask an additional question: what doesn't work in whom and why? Which is an important step towards correction. It's what's called gap analysis and correction. Where are the gaps? What worked? What didn't? How can we identify the nature and mechanisms of those gaps? And what do we need to do better? We don't know what doesn't work as well as what works, well, then clearly we're only working with half of the viable arm of what the research enterprise is actually enabled to do. And the last point is the relative legality and therefore liability of recognizing that something didn't work, or that something produced effects that were, if not beneficial, perhaps not even necessarily harmful, but burdensome. And isn't there the need to warn? And isn't that also an ethical issue in terms of non-malevolence, not wanting harm, but affording some extension of needing to do good and wanting to do good by informing the public and those individuals, as well as other professionals, simply what doesn't work and what not to try, to waste their time. If they do want to try, by them those methods that they could either try to reproduce and therefore get around any shortcomings, or modify in those ways where a simple modification might be able to lead to a beneficial end. Mr. Procaccino, anything on the legal side that might be important to add to the discourse?
I think you've said it all extremely well there, Jim. Again, you know, your commentary is analogous to the current situation that we see, say, with the vaccines for COVID-19. When you have a vaccine, say, that is discovered later on that there may be a tiny percentage of the population that receive the vaccine that may have some kind of problem, the importance of actually being transparent about that may at first result in kind of a negative reaction about the efficacy of the vaccine overall. But as explained by the professionals, it actually is beneficial to the population because it shows a couple of things. Number one, that we are being vigilant, looking at the goods, bads, and uglies of things that are still considered in the experimental or emergency use stage. And then secondly, it shows a sense of objectivity, that if all you're going to tell is the good, then and you're hiding the bad and ugly in the back, what else don't we know? And that only then exacerbates the lack of trust that we have in these research kind of entities. So obviously, very, very well said, Jim. Thanks.
And isn't that such a great point to be able to report our shortcomings effectively, or things that are probably negative? This can even be beneficial when it comes to case reports and case series. So as Jim aptly pointed out, these need to be peer reviewed and they need to be sufficiently read over and made sure that they're of high quality. But if someone has a complication, even on the individual patient level, and they do a literature search to see if anyone else has ever had this complication and how they handled it, and it's not out there because people are too nervous to publish their complications that they may be perceived as a bad doctor, that doesn't help the next person who has the same complication. And it's going to happen again. So I think sort of swallowing our egos in a sense and putting it out there for, moving it up the notches, as Jim pointed out, to the greater good, to the public good, to say, if the complication happened to me, it's probably going to happen to somebody else. So I may as well put out there what happened to me and how I handled it. For better or worse, learn from it. This is how it went.
Fabulous. Great.
Let me just put a little bow on this, if I may, so that we can really give our listeners and our audience some tools so they can clear hot to publish these kind of things. There's going to be some pushback. To this day, and I can tell you as a journal editor myself, many of my colleagues are, if not completely removed from, at least a bit reticent to publish negative findings, particularly given the fact that open publishing requires fees, and in some cases there may be limitations in terms of space. But I think the field is changing. Editorially, the field is changing, and some of the debacle, if you will, of big pharma and big past have served to be precedent, prototypic, and provide that casuistic basis to say, let's not do that again. But here's how to be cleared hot. If what you're looking to do is publish negative findings, the discussion that I and my colleagues provided for you here, written, repeated, or paraphrased, I think might be viable in both the introduction to why the work is important. I mean, the literal introduction to the paper, and certainly in the discussion of those findings as to why dissemination of those findings is valuable to the field. So just a rule of thumb, and hopefully the information we've provided for you here provides a good go-by and also a toolkit to get that type of information into the published press.
Great. Thank you. Lots to think about, all very interesting. So this concludes our session for today. Thank you to everyone for attending and to our esteemed panel members for participating. We'll see you all next time. Have a great day.
Thank you.
Thank you.